Thank you for joining a Collegial Conversation with Diana Clark. Today, Maria Kratsios is joining us to discuss the complexities and treatment modalities for trauma and PTSD. Maria is a psychotherapist based out of New York who specializes in the treatment of PTSD, complex trauma, mood disorders, and substance use disorders. Maria is passionate about helping her patients understand and change the patterns that make them feel stuck and begin a path of emotional, psychological, and spiritual growth. Thank you for joining us today, Maria. I will now pass the conversation on over to Diana.
Thank you, Laura. And thank you, Maria, for joining us. I am very curious about teasing out complex PTSD, from frankly, diagnoses of borderline personality disorder. So I am thrilled to talk to an expert. Thank you for joining.
You're welcome. Thanks for having me.
So I'm going to start with a simple question. How do you define trauma? Maybe that isn't a simple question, but
it's a good question because in the midst of the pandemic, people who never, I think, considered themselves to have any interaction personally with trauma at all are suddenly thrust into what by any definition would be a traumatic experience. So what do we mean by trauma? So the way I define trauma, the way I use it in my practice is when we are in a situation where our nervous systems are sent into fight or flight, what we call fight or flight. So when we experience a physical threat or an emotional threat that our nervous systems interpret as sufficiently upsetting, threatening to us, our nervous systems automatically respond with what we call fight mode or flight mode.
What about freeze? What about freeze?
I'm going to get to that. Oh, dear. On it. So yeah, so that eventually happens, but it doesn't necessarily happen. If we can successfully fight or flee, right? We could still call it trauma, but it's not going to lodge in our nervous system as a trauma because we succeeded in getting ourselves back to safety, right? So it isn't
the event. So it isn't the actual event. It is our response to the event.
It is our response to the event. So when we cannot sufficiently fight or flee, our nervous systems get very activated. And eventually it overloads. Think of an air conditioner that blows the fuse box, right? System shuts down to protect itself, and that's what we call freeze. And from a polyvagal theory standpoint, we drop from fight flight into dorsal vagal, which is a lower level, if you will, in the nervous system, and the polyvagal nerve. And the freeze can look like a lot of things. We could dissociate, we could literally fall asleep. I've had patients fall asleep in session. We could forget that the trauma happened. That's a form of freeze. It can take many forms. So even that, although we would call anything that results in that cycle a trauma, doesn't necessarily result in PTSD, post-traumatic stress disorder. And that's a little different than what you asked me, but if you're interested in the connection, we can talk about.
So, yeah, I would love to, because I had one of those experiences young, being chased and grabbed by a big boy, and I was able to turn around and I fought and I fled. I did both and I got away. I don't see that in myself as a trauma. And I've always sort of wondered, what was it about that? Why didn't it create anything walking down the street? I'm not more nervous. It is a very different experience.
Yeah, because you were successful, and our nervous systems are safety seeking. So if we can sufficiently get ourselves to safety, and sufficient is a subjective thing. It's whatever your nervous system can tolerate. So in your case, you sufficiently got yourself to safety. And even if you hadn't, even if, let's say, something had happened more significant and you started having reactions afterwards. Maybe you did for a little while develop a fear of walking down the street, or having, panic attacks or things that sometimes happen. Even then, it doesn't necessarily become a long-standing, or I don't want to say permanent because it can be reversed, but long-standing impact on our nervous system that results in what we call PTSD. The difference lies in what is the level of internal and external resources that the individual has available to them to process and move through the experience, make meaning of what happened, and integrate it into their experience of the world as safe enough, trustworthy enough, caring enough, protective enough, etc.
So you're a good enough participant in this world too. I am a fan of Winnicott's Good Enough Mothering, and I look at that as this is good enough, and good enough has to be the standard. Yeah.
Right. Exactly. So what, unfortunately, one of the symptoms or side effects of PTSD is that there is no good enough anymore. We're robbed of we either lose, if we had an experience of good enough, safe enough, trustworthy enough, we lose it as a result of the trauma. Or if it happens early enough in our childhood, we may never have had it in the first place. So we, in the first place, learn that the world is not safe enough. So we develop an experience of needing the world to not be safe enough, but to be 100% safe, 100% trustworthy, which it can never be. And we live in a state of constant hypervigilance.
That amygdala, right? The amygdala is where that, right in that midbrain, is lit up all the time.
Yeah, the amygdala, the limbic, this is very much, fight flight is a limbic response. Our limbic brains are recruited in that moment. So think about this. I live in New York City. So you're walking off the sidewalk in New York City. Maybe you're maybe I'm on my phone. I'm not paying attention. I'm distracted. I take a step off the curb and notice just out of corner of my eye that a bus is coming. I don't have to stop and reason and think about, my prefrontal cortex does not engage. My limbic completely overrides and jumps back. It's a flight response, right? It already knows, don't try to fight the bus.
No.
Way. Flee, right? I don't have to think about it. If I had to think about it, I'd be dead, right? Yeah, so this is fight, flight by definition. Whenever we're under threat, our limbic system becomes engaged. And when that happens, you mentioned at the start that you're curious about the difference between PTSD and complex trauma. And I am too, because it's an ongoing source of frustration that complex trauma isn't a diagnosable thing in any official medical way. It's hard to research. We all know it exists, but what is it? How do we define it? PTSD is defined more narrowly as, the traumatic event. PTSD does not depend from a diagnostic standpoint on the effect, only on the effect it had on your nervous system. It actually, the trauma itself has to fall into certain categories. It has to be a physical, either the personal experience or the witness of a physical threat or a sexual threat, essentially, right? But what happens if we grow up, as you very wisely pointed out right away, it's a question of how it affects your nervous system. So if I grow up in a household where I am continually being emotionally undermined, I'm told I'm no good, I'm, whatever the situation might be, even if there's no physical abuse involved that rises to that level, or sexual abuse, eventually it can work on my nervous system as a similar kind of threat, because my prefrontal cortex is not developed. So our prefrontal cortex isn't developed until now we think it's until we're about 20. Yeah, 30. We keep raising.
Depends if you're a man or a woman. Women develop it quicker. Yes.
Makes sense. The result is that threats that don't rise to that level, but that aren't the diagnostic criteria, but that nonetheless present, I'm little, the big people are big. They hold a tremendous amount of power over me. And I don't have the cognition, I haven't developed it yet to step back and see myself in the context of, what's going on. I'm very narcissistic, appropriately so at that age. I see the entire world revolving around me. Of course, it's my fault. I can't make sense of it. So that is really what we call complex trauma. It's caused by what we call adverse childhood experiences.
All right, so here's the trickier question. Since we don't have a diagnosis of complex trauma, and we do have a diagnosis of borderline personality disorder, which very often must mimic some of the symptoms of complex trauma, are there people who are diagnosed with borderline who should probably be, if there was such a diagnosis, diagnosed with complex trauma?
Absolutely, in my estimate. It's we think alike, you and I. That is, I see personality disorders and borderline in particular as on the continuum. And I'm sure there may be people watching who's saying, what? But I approach it similarly from the perspective of understanding what it is I'm treating. Now, my approach might differ. What I bring to bear in the therapy room might differ depending on how the trauma is presenting. But that's true whether it's borderline personality or anything else, or substance use or anything, right? So we always want to look at what is presenting in the room as a problem, and let's intervene with an approach that is going to be most helpful at this time. It's highly likely that that approach will need to change over time as the person's nervous system adapts. But if you try to use one approach and you just have, one way, and that's not what the patient responds to, you could even end up re-traumatizing the patient.
I can see that. I worked in a residential program with young women at one point, and I noticed all of them had big T or little t trauma. It was a substance use program. It was young women. It was, every single one of them, whether they had it when they started drinking or using, they have it by the time they get to treatment, just because of sexual assault or that kind of history. What I noticed, and I don't know if this gets embodied in therapy or not, beyond the actual connection between a therapist and a patient or a client, is that oxytocin seemed to do more for their nervous systems, calming them down, than almost anything else. And I saw them as people who were seeking sexual encounters potentially to elevate oxytocin when they were seeking that calm feeling. So do you use that?
You've just given a voice. You've completed the triumvirate of polyvagal theory. We talked about fight flight. We talked about dropping down into freeze, which is dorsal vagal. So oxytocin is ventral vagal. It's rising up out of fight flight and into a state of well-being, an experience of well-being, of calm, of connection to self, to higher power, to each other. It's one of the reasons that the pandemic is traumatic by definition, because we are safety seeking, and when we're under threat, and one of the ways that we bring that safety net is to connect with others. And especially during the start of the pandemic, we could not connect to others because that person could be the threat. So it was quite insidious, quite difficult for our nervous systems in general to tolerate that, right? Someone with who's the function of their substance abuse is what you just described. They're just trying to they don't have the skill. They simply don't have the skill to pull themselves out of fight, flight, and dorsal into ventral. And so they do it artificially. Yeah.
That's right. That's right. We worked on a platform of how to elevate oxytocin without sex, basically, because they were in treatment. That wasn't a possibility. So,
what were some of your discoveries? What did you find?
Okay. Do you want to know? Really?
I'd love to. Yes. It's
Okay.
what we all need to know and do for our patients.
Singing together. Huge singing together. We would put on a video and everybody would sing and maybe dance a little bit. That was a really important elevation of oxytocin for them. Music, choral music.
Choral music. So interesting that that's the first thing you named, because I hear two things happening in that intervention. One is community, right? The connection to others. So doing it together, which is huge. The other is sound. And this is a kind of cutting edge growing area that I'm not an expert in, but others are, and you know, we're learning about, which is the impact of sound on our nervous system, regardless of whether you have PTSD or not, but specifically vibration of the inner ear. It's so interesting. So there's actually Stephen Porges, who you may have heard of, who's kind of one of the most prominent theorists of polyvagal theory, has developed something called Safe and Sound Protocol, where there's the generation of a humming sound. I don't know exactly, actually, but I'm really interested in it, in part because I'm very spiritually oriented in my practice and helping people connect to make meaning of, you know, their trauma, by drawing on whatever spiritual connection they may have. And all the major spiritual traditions have chanting and gongs and humming as part of their practice. And maybe it's not an accident. So.
Right. And it's not an accident that there are women who describe nursing as maybe the first time in their life they felt entirely safe. That's not accidental either. Yeah.
Yeah, that experience of being whole and complete in connection with other, and
Oxytocin flooding and
Yeah.
all of those things. Yeah. Not every woman, but certainly when I talk about oxytocin, they say, well, what's the best way to get it? And I'm like, well, sex or nursing a baby, but we're going to figure out less connected ways. So in addition to music, random acts of kindness, little notes to each other in surprise ways, thinking about somebody else. Yeah.
Yeah. So from a treatment theory perspective, I see that again through the lens of connection to others. It's why group therapy is so important in trauma treatment. And also the experience of having agency. So what trauma does is it robs us of a sense of agency. By definition, we have an experience of powerlessness. Mm-hmm. And the powerlessness, by definition, is so great that we can't tolerate it, which is why we have to drop down into freeze mode. We have to dissociate from it. And the hallmark of PTSD is avoidance. We find ways to avoid the experience of powerlessness, the experience of grief, these deepest and hardest emotions to work through, right? All of that caused by a loss of a sense of agency. Right. So when we are able to change our own experience or the other person's experience through a random act of kindness, even if it's just for a moment, we are not only is it what we call a top-down, you know, I can change my belief about the world and about myself in the world, but it's also bottom-up because our nervous systems feel good. It's like, oh, and then I'm moving myself up that ladder into ventral vagal.
I love that. I love that. The idea that there is a biologic response to doing good deeds. that makes me think of a higher power for sure. Just how we're built.
Yeah, how we're
How we're
built.
built. Humor is another way I notice people get, elevating their calm and reducing cortisol. Yeah.
Yes.
Humor, laughing,
Yeah.
crying. I think what I'm really getting is that when I was back in my youth and had my own therapy, the one line that my therapist used to say over and over was, every feeling fully felt passes. It is the ones you don't feel that go sideways. And if what you're describing with PTSD or complex trauma, or in some ways borderline personality, when they're symptomatic, they're seeking to not feel the feeling.
They're seeking to not feel that feeling, the powerlessness, the grief, that whatever it is that in its own wisdom, their psyche has decided they can't tolerate. Which brings us back to, if you have sufficient internal and external resources to carry yourself through it, you'll feel all those feelings. It'll be awful, but you will get to the other side. Those feelings will be felt and they will expire. Those are the natural feelings that fall out of the trauma. I would add something to your therapist's comment, which is because there are other feelings we feel that actually don't go away. For example, if there's a 10-year-old girl who's sexually abused by her older brother for a little while, and then it stops and nothing's ever done about it because no one knows, etc. But this is something she's carrying with her. And let's just say that she enjoyed it a little. So now she has the disgust of what happened. That's a natural feeling. Right? She also has a tremendous amount of guilt because she has learned to tell herself that the reason it happened is because I enjoyed it. I asked for it. So that's a cognition. It's a distortion, but her prefrontal cortex is not fully developed. And no one is attending to her distortion. So she doesn't know it's a distortion. It lives in her as if it's true. It gets lodged in her brain as a truth with a capital T. So that belief turns the disgust on self. I'm disgusted with myself. And I also feel guilty because I did something wrong.
And what you're also describing is she may have loved her big brother. It may that just go away.
Complexity upon complexity, right? This is why I would call it complex trauma. It would be both PTSD and complex trauma. So right. And so all kinds of other distortions that we don't have time. The list, I mean, when I go through these with my patients, we could have 10 pages of beliefs, of distorted beliefs. Okay. All of the emotions that fall out of those distorted beliefs, like the one that I just gave an example of. So we're talking disgust with self and guilt. As long as she holds that belief, that feeling is fully felt. It will not expire. It will not. So we need to address the distorted cognitions sometimes, like singing, it doesn't go far enough. Like intervening directly on the nervous system. If I have that belief and it's lodged as a truth,
right,
yes, I find a way to unlodge it, right? On the other hand, unlodging from that belief doesn't go far enough, in my experience, when the trauma occurs, especially if the trauma occurs at an early age, because our nervous systems, our bodies are simply holding such a depth of, pain and dysregulation that we can't tolerate the transition from fight, flight into dorsal vagal. We literally can't tolerate it. Our nervous systems kind of explode, they go on fire. So we need what we call bottom-up approaches, which are somatic interventions, holding, rocking, breathing, sleeping under a heavy blanket, swimming in the ocean, sound, things that we just purely have kind of no meaning other than I'm just taking care of you. Because taking care of our nervous system.
Nice. So anything else? We have just spent our time. Anything else you would like to add today to our conversation? This was amazing. I have learned an enormous amount, so I'm thrilled.
And I love talking about these topics because some of it is counterintuitive. You know, we in our sometimes when we're bringing the best we have to a friend, to a spouse, to a colleague, to a child, we can say things unwittingly that actually further the trauma without meaning to. Like our daughter comes and tells us she was raped and it happened a year ago, and mom spontaneously says, "Why didn't you tell me?" Which is, of course, that's what we say, but that now it's my fault that I didn't tell. So now I have added.
Right. That's really good advice. I would love for all of us to remember that one, because it is instinctive to ask, why didn't you tell me?
Yes. And so I would just hope that we all kind of hit the pause button, because we're all living through a trauma together. And the person we pass on the street who overreacts because we bumped into them or whatever it is, you know, that person's nervous system is overstimulated. We're all in at least a little bit of fight flight. We all need to be continually intervening on ourselves at this time. We always do, but now especially, because we're not out of the woods yet with the pandemic, and the whole broadest community is at risk in a way. And so finding ways to tend to ourselves and also find that compassion and allowance for others who, you know, are going through whatever they're going through.
I love that. Thank you, everybody. Please take away Maria's kind words and her gentle approach to dealing with people with PTSD, complex trauma, and potentially diagnoses of borderline. Have a great day, everyone. Thank you.
Anna.